Good morning, everyone. Myself, Dr. Prem Garg. I am professor in the Department of Pathology, Santosh Medical College, as well as I am Dean Students Welfare, Santosh Deemed to be University. So, whenever you have any problem in anything in the university campus, you please inform and discuss with me. Today, we are going to discuss a very important topic, diabetes mellitus. Diabetes mellitus in common population is called as sugar. Now, diabetes mellitus usually consisting of two words, diabetes and mellitus. This diabetes usually comes from the Greek word for siphon, and the meaning of siphon is that a lot of urine is made. The second term, mellitus, comes from the Latin word, and the meaning is smell, which means honey, and it was used because the urine was sweet in nature. So two important things regarding diabetes mellitus is there, that a lot of urine is made and the sweet nature of the urine. That's why the name diabetes mellitus was given. The Indian physician Sushastra in the 6th century BC noticed the sweet nature of the urine in such patient and termed the condition Madhumeh. So you can say Madhumeh is popularly called in Ayurvedic medicine as diabetes mellitus. The human pancreas, anatomically, it is a single organ, but histologically and functionally, it consists of two distinct parts, endocrine pancreas and the exocrine pancreas. Before going in the detail of endocrine and the exocrine pancreas, we must understand what is gland and what is endocrine gland and what is exocrine gland. So glands are the structures of the organ in our body which secrete certain chemical substances, and these substances later on come into the either in the different parts of the body or into the circulation. So endocrine glands, which are ductless gland, and they secrete certain substances which directly come into the circulation, while exocrine glands, they secrete certain substances, chemical substances, which through ducts come into the different parts of the body. So you can say endocrine glands, they are the ductless gland, and the exocrine glands, they are the glands which are provided with the duct. The same things apply here, endocrine pancreas and exocrine pancreas. Exocrine pancreas, they are the glands which are provided with the ducts, and they secrete certain substances which we call as enzymes. They come into the intestine, while the endocrine pancreas, they are the ductless gland, and they secrete certain chemical substances which we call as hormones, and directly they come into the blood circulation. Now come to the anatomy of the endocrine pancreas. Usually endocrine pancreas consist of microscopic collection of cells which are known as islet of Langerhans, and these islet of Langerhans, they are greatly concentrated in tail of the pancreas. I think we have already studied in anatomy that the pancreas is divided into three major portion, that is the head, body and tail. So islet of Langerhans, they are greatly concentrated in the tail of the pancreas. Ultrastructurally and immunohistomically, four major and two minor type of islet cells are distinguished. Ultrastructurally means on electron microscopic examination, and immunohistochemically, as the name is indicating, when we are using certain histochemical stains applying with the immunological principle, then the condition is called immunohistochemistry. Now come to the major cell type. The different cell which fall in this category, they are divided into, number one is beta cells or B cells. They are most common and approximately constituting 70% of the total islet of Langerhans, and these cells, they secrete insulin, and the deficiency of this insulin hormone is responsible for hyperglycemia. In other words, you can say it is responsible for diabetes mellitus. Second major cell is alpha cell or A cell. They are second most common, constituting 20% of the total islet of Langerhans, and they secrete a hormone called as glucagon, and deficiency of this glucagon is responsible for hypoglycemia. So with these two type of cells, we can say glucagon and insulin, they have opposing regulatory effect on glucose homeostasis. So deficiency of insulin is responsible for hyperglycemia, while the deficiency of glucagon is responsible for hypoglycemia. Beside these two major cells, the third one is delta cells or D cells. They are usually 5 to 10% in nature, and they secrete an important hormone which we call as somatostatin, and this hormone is also responsible for suppressing both insulin and glucagon release. The fourth major cell type is pancreatic polypeptide, which is also called as F cells. They are usually 1 to 2 in percentage, and they secrete pancreatic polypeptide, which are having some GIT effects. Now come to the minor cell type. As the name is indicating minor, that they are very less in number, and these include number one is T1 cells. They elaborate certain gastrointestinal peptide, which is shortly called as VIP, and this is responsible for secretory diarrhea. The second minor cell type is enterochromaffin cells, which is responsible for the synthesis of the serotonin, and this serotonin may induce carcinoid. Now the most important definition. What is the definition of the diabetes mellitus? So every word is very, very important to understand the definition of diabetes mellitus. Number one is it is not a single disease but a group of heterogeneous metabolic disorders. Now it is characterized by common feature of chronic hyperglycemia. Why? It results from defects in insulin secretion or insulin action or both, with disturbances of carbohydrate, fat and protein metabolism. So with this definition, what we are concluding? We are concluding that number one, it is not a single disease, it's a group of diseases, number one. Number two is that they are having a common features of chronic hyperglycemia, means increased blood sugar, and this chronic hyperglycemia, it usually results from either there is a deficiency of insulin, or sometimes insulin is there but the action of the insulin is not up to mark, and it is usually associated with disturbances of carbohydrate, fat and protein metabolism. This is a very, very important definition, and everybody should learn the definition of diabetes mellitus, because so many times it will be asked a part of long question and sometimes it will be asked in your oral examination. Now, diabetes mellitus, it is the leading cause of morbidity and mortality. I think you are aware with these two words. Morbidity means disease or illness and mortality means death. So this is one of the leading cause of not only illness but responsible for the death. And it continues as a major health problem all over the world owing to its serious complications such as end-stage renal disease, or in other words you can say they are responsible for the renal failure. IHD stands for ischemic heart disease, and the gangrene of the lower limbs and blindness in the adults. So these are the few complications which can ultimately lead to death of the patient. It is one of the most common non-communicating disease, or you can say non-infectious disease, along with cardiovascular system, cancers and respiratory diseases. Now come to the incidence in India. 7% of the adult population, I'm talking about adult population, usually diabetes mellitus is present, and it is usually type 2, which is more common in such population. And why it is so common? Because of due to genetic susceptibility, which is associated with high caloric diet, reduced physical activity and obesity in Indian middle class. So as you are seeing the diagram here, in the last diagram we are seeing the obesity is there. We are taking the high caloric diet and there is reduced physical activity, which is responsible for the diabetes mellitus, especially in the adult population, and usually more common in either in the higher middle class or in the higher class. Now come to the classification in the etiology, or in other words you can say the etiological classification of the diabetes mellitus. There were older classification which divides diabetes mellitus into several types. First we'll discuss the older one and then we'll discuss the newer one. The first older classification is primary and secondary types of diabetes mellitus. Second older classification is juvenile onset and the majority onset diabetes mellitus. And the third one is insulin dependent diabetes mellitus and the non-insulin dependent diabetes mellitus. But now or recently these classifications, they are obsoleted. Why? Because of the extensive understanding of etiology as well as the pathogenesis of diabetes mellitus. Again, there are two medical words. Etiology means cause of the disease and the pathogenesis is mechanism of development of the disease. So these are the two factors by which the older classification they have replaced by the current classification. And this current classification, as I just told you, based on etiology, divides into two broad categories: type 1 diabetes mellitus and type 2 diabetes mellitus. So nowadays this classification is more prevalent, and whenever you are going to see any prescription, you will see the patient is having history of diabetes mellitus, and in bracket most of the doctor, most of the clinician, they used to write type 1 diabetes mellitus or type 2 diabetes mellitus. So this etiological classification of diabetes mellitus, as I just told you in the previous slide, the major types are type 1 diabetes mellitus, which is responsible of total 10% of the total cases, and this type 1 diabetes mellitus is further subdivided into type 1A diabetes mellitus and type 1B diabetes mellitus. Type 1A diabetes mellitus, it is usually immune mediated, and type 1B diabetes mellitus, it is idiopathic in nature. And idiopathic, I think everybody is familiar, when the cause is not known, the condition is called idiopathic. Second type is type 2 diabetes mellitus. It is the major type of diabetes mellitus of the total cases of the diabetes mellitus, and approximately constituting 80%. The third category, usually other specific type of diabetes mellitus, which usually constituting about 10% of the total cases, and it includes a long list which is responsible for the diabetes mellitus. Namely, whether there is a genetic defect of the beta cell function due to mutation in the various enzymes, genetic defect in the insulin action, certain endocrinopathies, certain drugs or chemical which are responsible for induction of the diabetes mellitus, certain infections are also there, and some uncommon form of immune mediated as well as the genetic syndrome which are also responsible for the diabetes mellitus. Now the fourth one is gestational diabetes mellitus. This is again a very important cause which is associated with diabetes mellitus. We'll discuss in the next slide. Type 1 diabetes mellitus, as I told you in the last slide, usually 10% of the total cases, previously known as juvenile onset diabetes, due to presence in younger age group. And when we are talking about juvenile, so usually the meaning of juvenile is that between 16 to 18 years of age group, the patient is called as juvenile. And it was called insulin dependent diabetes mellitus. The reason being that the insulin was required for solely treatment in cases of type 1 diabetes mellitus. But according to new classification, it is neither truly is nor insulin dependent. So nowadays, this classification is being obsoleted by type 1 diabetes mellitus. Type 1 diabetes mellitus is further subdivided into immune mediated, which is also called as 1A. Why? Because it is characterized by autoimmune destruction of beta cells and ultimately leads to insulin deficiency. So autoimmune means self-immune means our immune system. So certain chemicals, you can say the certain substances, they are developed against own immune system, ultimately responsible for the autoimmune destruction. In the second, we are repeatedly discussing idiopathic, which is also called as 1B, and idiopathic where the cause is not known and it is negative for autoimmune markers. So this is few words about type 1 diabetes mellitus. Now type 2 diabetes mellitus, as we have discussed in the last slide, about 80% of total cases of diabetes mellitus, previously called as maturity onset diabetes, as the name is indicating, it was more common in older age group, and it was called as non-insulin dependent diabetes mellitus of obese and non-obese type. So as the name is indicating, it was not dependent on the insulin, or insulin was not required. But again, nowadays it is neither truly is nor non-insulin dependent. Now few words about gestational diabetes mellitus. So gestational means the diabetes mellitus which is seen in pregnant women, and it is seen in approximately 4% of total pregnant women. They are diagnosed diabetes mellitus during pregnancy, and this is more common in either in second trimester or in third trimester. At this moment, you must know usually the pregnancy is divided into three trimester: first trimester, second trimester, and third trimester. And roughly you can calculate the first 3 months is usually first trimester, second 3 months is second trimester, and the last 3 months, that is third trimester. And here there is no previous history of diabetes mellitus, but due to certain metabolic changes which usually revert back to normal after delivery. So you can say 4% in pregnant women, they are first time being diagnosed in pregnancy, and they usually come back to normal after delivery. But what precaution you have to take, that these women are prone to develop diabetes in the later life. So we have to be very particular about not only the education of these patients but also the monitoring and the follow-up. Gestational diabetes may be transient, but if we are not treating gestational diabetes, they can damage the health of the fetus as well as mother. The most important risk of the baby is number one, macrosomia, which is called as high birth weight. Whenever the birth weight is more than 4 kg, then it is suspicious of the diabetes mellitus. The mother is suffering. Certain congenital heart defects, they are also common in babies when the mother is having diabetes mellitus. Certain central nervous system abnormalities and certain skeletal muscle malformation, they are also common if the mother is suffering from diabetes mellitus. Now, pathogenesis. Depending upon the etiology of diabetes mellitus, hyperglycemia may result from number one, reduced insulin secretion. So whenever there is a deficiency of the insulin, either due to the deficiency in the synthesis or due to the deficiency in the release of the insulin. Second one is decreased glucose utilization by the body. So in other words, you can say here there is not absolute deficiency of the insulin, but the peripheral tissues, they are not responding to insulin, resulting in decreased glucose utilization. The third one is increased glucose production in the liver. So these are the three main mechanisms which are responsible for the increased blood sugar, or you can say hyperglycemia or diabetes mellitus. So few words about normal insulin metabolism. Insulin and glucagon, we have already discussed that they are having opposing regulatory effects on glucose homeostasis or the glucose metabolism. The major stimulus for both synthesis, which usually takes place in the beta cells of the pancreatic islet of Langerhans, and release of insulin is glucose. So you can say glucose is the key regulator for both synthesis as well as the release of the insulin. So clinically, it is being advised in most of the diabetic patients that they should take small and frequent meal instead of three major meals, because as we know that glucose is not only required for the synthesis but also for the release of the insulin. Now, in case of type 1 diabetes mellitus, we have already discussing that type 1A, it is usually immune mediated. In other words, you can say it is autoimmune in nature, and here the basic phenomena is the destruction of beta cell wall, ultimately usually leading to absolute insulin deficiency. So this is a very important thing regarding the type 1 diabetes mellitus. So whenever we are suspecting diabetes mellitus, especially type 1, we have to check the insulin level. Type 1b, it remains idiopathic. It means there is no known cause. Type 1a is explained on three interlinked mechanisms. What are those? Number one is genetic susceptibility, second one is autoimmune factors, and third one is environmental factors. So these are the three interlinked mechanisms which are ultimately responsible for maximum cases of diabetes mellitus in type 1a. Clinical features of diabetes usually manifest whenever there is more than 80% of beta cells, they have been destroyed. So now you can think of until our 4/5 of the pancreas is not damaged, it is very rarely to have significant clinical features. Now come to the type 2 diabetes mellitus. Here the basic metabolic defects, they are number one is impaired insulin secretion. What does it mean? It means whenever there is a delayed insulin secretion relative to glucose load, it is called as impaired insulin secretion. And or insulin resistance means peripheral tissues, they are unable to respond to insulin. So in both the cases, you can say there is no absolute deficiency of the insulin. Either there is a impaired insulin secretion, means insulin is not getting secreted on the proper time whenever demand is there, and second one is the peripheral tissue, they are not responding to insulin. Here, no HLA association and autoimmune phenomena are implicated, as they are more prevalent in type 1 diabetes, especially 1A. Now come to the major risk factors for type 2 diabetes mellitus. In other words, we can see the person who are more prone to get type 2 diabetes mellitus. Number one is certain medications. They are responsible for the induction of diabetes mellitus. Recently, we have seen in COVID patients where the lot of steroids were advised by doctors or by different means, they are ultimately responsible or they land up ultimately in high blood sugar. Diabetes mellitus type 2 is common in certain race, and the patient who are having high blood pressure, whether it is controlled by the blood pressure medicine or without blood pressure medicine, they are strongly associated with diabetes mellitus. Stress, mental and the physical stress, sometimes they may also precipitate type 2 diabetes mellitus. Age, as I told you, that diabetes mellitus type 2 is more common in older age group, usually more than 45 years of age. Inactivity, whenever there is a reduced physical activity, it is also responsible for the precipitation of type 2 diabetes mellitus. Pregnancy, as we already discussed, the gestational diabetes mellitus. High cholesterol, it is also somewhere related with the type 2 diabetes mellitus, more cases. Obesity, again we have discussed, obesity means whenever BMI is more than 30, then the patient is called as obese. And BMI, I think everybody is familiar, that is the body mass index. So whenever it is more than 30, then the patient is supposed to called as obese. And family history. The family history is also very, very important. And if there is family history, then also we should not only educate such persons, as well as we have to monitor and we should regularly advise them to go for test to see whether the blood sugar level is normal or it is increased. So in type 2 diabetes mellitus, hyperglycemia is not due to destruction of beta cells, but it is usually due to failure of beta cells to meet the requirement of insulin in the body. So in other words, we can say number one, type 2 is more complex and multifactorial disease, because in the last slide we have seen so many risk factors which can be associated with type 2 diabetes mellitus. Number two, there is a greater role of genetic defect and heredity. So more common type 2 diabetes mellitus is seen in family. And the third one is insulin resistance and the impaired insulin secretion. We have already described these two words. They are the most important mechanism for hyperglycemia, and these mechanisms are again interlinked. This is diagrammatic representation showing the pathogenesis of type 1 diabetes mellitus and pathogenesis of type 2 diabetes mellitus. As we have already discussed, type 1 diabetes mellitus, they are linked with three interlinked mechanisms. They include genetic susceptibility, environmental factors, and autoimmune factors. And ultimately, they are responsible for type 1 diabetes mellitus. While in type 2 diabetes mellitus, again it is a multifactorial disease, and here the genetic factors, certain constitutional factors in the form of obesity, hypertension, low physical activity, decreased insulin secretion and insulin resistance, we have already in the previous slide, and they are again responsible for the maximum cases of type 2 diabetes mellitus. Now, few words about clinical features. Clinical features, somewhere they are usually tells us about the type 1 diabetes mellitus or type 2 diabetes mellitus, although there may be overlapping in the clinical feature. So sometimes we cannot say just seeing the patient is having type 1 diabetes mellitus but type 2 diabetes mellitus. But again, I'm telling you, certain clues are there, certain clinical features which are very, very significant and ultimately tells us about the type of the diabetes mellitus. The few of them are in type 1 diabetes mellitus, as we are saying, it is usually seen in early age group, usually below 35 years of age group. But again, I am telling, this age is not an absolute criteria to make the diagnosis of diabetes mellitus type 1 or type 2. Number two clinical feature is abrupt onset. Usually it is sudden in nature. Third one is 3Ps, which are very, very important features seen in type 1 diabetes mellitus, and they include polyuria, means increased urination, polydipsia, increased thirst, and polyphagia, increased appetite, along with history of weight, the history of loss of weight. So basically you can say three important features, they are there along with history of loss of weight. So you can say increased appetite is there, but still there is a loss of weight. So same type of presentation, especially when we are talking about this polyphagia with history of loss of weight, is seen in hyperthyroidism. So we have to be careful about it. And type 1 diabetes mellitus, these patients, they are prone to develop metabolic complications such as ketoacidosis and hypoglycemia. Hypoglycemia means when the blood sugar level is less than normal, it is called as hypoglycemia. So there may be overlapping in clinical features, means whatever clinical features we are getting in type 1 diabetes mellitus, sometimes they may be present in type 2 diabetes mellitus. So we have to be careful because the treatment is different in type 1 diabetes mellitus and type 2 diabetes mellitus. In type 2 diabetes mellitus, usually we are discussing for so many slides that they are more common in usually more than 40 years of age group. But again, they can be seen in adolescent, especially in the obese children. So that's why again age is not an important criteria. Usually it is slow and insidious onset. Insidious means gradual in onset. Number three is asymptomatic or obese with complaining of weakness and loss of weight. So usually these patients, they do not have any sign and symptom, but sometimes non-specific symptom in the form of weakness and loss of weight is there. But again, the very important clinical feature is that the uncontrolled patients may present with polyuria, polyphagia, and polydipsia. So now you can see these features that the patient is having uncontrolled blood sugar, especially in type 2. These features may overlap with type 1 diabetes mellitus. So again, I'm telling you, there may be overlapping in the clinical features, so we have to be very careful because the treatment is totally dependent on the type of the diabetes mellitus. Here, the acute metabolic complications like ketoacidosis and hypoglycemia, they are infrequent, but it is being seen in type 2 diabetes mellitus, although it is more common. But if you compare about the type and severity with type 1 diabetes, they are infrequent. But again, as the number are more, you can say 80% of the total cases of diabetes mellitus. So overall, you will see the more patients who are having complications, they belong to type 2 diabetes mellitus. So diabetes mellitus type 1 sign and symptom in the picture form. We have already discussed the important three P's are there. That's polyuria, increased urination. Second one is polydipsia, increased thirst. And the third one is polyphagia, increased hunger. Beside that, weight loss is there. Again, a very important sign. So whenever these three features along with weight loss is there, so we have to make the certain diagnosis of diabetes mellitus, and then later on we have to differentiate whether it is type 1 or type 2. Beside that, fatigue is there, increased frequency of infection, and usually this increased frequency of infection can be there in the form of either the skin infection, there is a delay in the healing of the wound, certain infection around the genitalia. Sometimes TB and HIV is also very commonly associated with uncontrolled diabetes mellitus. Lung infections are there, ear infections are there. So whenever infection is there, especially in the middle age group, we have to go regularly check the blood sugar level. We have already discussed usually the onset is rapid or abrupt. There is these patients, they are insulin dependent, and most of the patients, they require for the control of the blood sugar insulin. They are early onset, as we are discussing. Usually they are more common in 35 years and less than that of age group. Now come to the type 2 diabetes mellitus. Here, sedentary lifestyle, or you can say in other words, when the patient is having lack of physical activity, there is more chance of development of type 2 diabetes mellitus. Usually familial tendency is there, so whenever there is a family history of diabetes mellitus, we have to seriously educate and monitor the patients. Usually the average is more than 45-50 years. The different literature, they are seeing the different age group, but in short, if they are more common in the older age group, then we have to think about the type 2 diabetes mellitus. Whenever there is history of blood pressure, whether the patient is taking medicine or not taking medicine, and the blood pressure is not controlled, they are more susceptible to have this type 2 diabetes mellitus. Again, fatigue, decreased energy, so these are the non-specific sign and symptom usually seen in type 2 diabetes mellitus. Again, recurrent infection as in type 1 diabetes mellitus, especially when there is uncontrolled blood sugar, there is more and more chances of having recurrent infections. So till now, whatever we have discussing about the diabetes mellitus in the different type, whether it is type 1 or type 2 diabetes mellitus, they are summarized in the tablet form, and on the basis of that, we can differentiate easily type 1 diabetes mellitus and type 2 diabetes mellitus. And this table is very, very important, because if you remember, if you understand this table, not only you can write diabetes mellitus in detail, but also it is a part of a theory paper which is frequently being asked as a difference. Along with that, type 1 diabetes mellitus and type 2 diabetes mellitus, so many times these differences are being asked in your oral examination. So just to summarize in short, the frequency we have already discussed. It is type 1 is less common, usually 10%, and type 2 is approximately 80%. Age of onset, usually it is less than 35 years, while type 2 diabetes mellitus it is more than 40 years. Type of onset we have already discussed. Usually it is sudden in onset, while type 2 diabetes mellitus is gradual in nature. In type 1 diabetes mellitus, weight is usually normal, but in type 2 diabetes mellitus, it can be obese or it can be non-obese. HLA usually linked to HLA DR3, HLA DR4, and HLA TQ, while there is no HLA association is being seen in type 2 diabetes mellitus. Family history is usually in less than 20% of cases, while usually in type 2 diabetes mellitus patient it is approximately 60%. Genetic locus, it is usually unknown in type 1 diabetes mellitus, while chromosome 6 it is in type 2 diabetes mellitus. But this is a wrong information. This table is taken from the Hirschman textbook of pathology, but usually seen this chromosome 6 is usually associated with HLA, and it is more common in type 1 diabetes mellitus rather type 2 diabetes mellitus. Diabetes in identical twins, usually it is seen in 50% concordance, while in type 2 diabetes mellitus it is 80% concordance. The concordance meaning is that if in identical twins, if the one twin is having diabetes mellitus, then there is 50% chances of development of diabetes mellitus in the other infant, while in type 2 diabetes mellitus, if one twin is having diabetes mellitus, there is maximum possibility approximately 80% of development of diabetes mellitus in the other twins. Pathogenesis, as 1A is more common, so there is autoimmune destruction of the beta cells in cases of type 1 diabetes mellitus, but in type 2 diabetes mellitus, we have already discussed insulin resistance is there and impaired insulin secretion. Islet cell antibodies, as it is autoimmune destruction, though definitely they are seen in type 1 diabetes mellitus, but they are not present in type 2 diabetes mellitus. So blood insulin level, because autoimmune destruction of the beta cells ultimately responsible for the absolute deficiency of the insulin. So blood insulin level that is decreased in type 1, but either it is normal or increase in type 2 diabetes mellitus. As I told you, here the insulin is there, but the action of the insulin is not proper. Islet cell changes, they are definitely, because the autoimmune destruction is there, so they are seen in the type 1 diabetes mellitus, but in type 2 diabetes mellitus they are not seen. Amyloidosis, that is infrequent in type 1 diabetes mellitus, but it is more common in type 2 diabetes mellitus. Clinical management, usually in the form of insulin and diet, that's why previously they are called as insulin dependent, but in type 2 diabetes mellitus, it is usually diet, exercise, oral drugs, and sometimes some patients they need insulin for their treatment. Acute complication we have already discussed, that is more common in the form of ketoacidosis and hypoglycemia in type 2, while acute metabolic complications they are infrequent and usually they include hyperosmolar non-ketotic coma.